you have an essay on the importance of William James called The Search for Wisdom.
Yes.
And it is this philosophical side which I also want to hear from you about. For example, you mentioned in the essay that the questions of uncertainty and danger in the world are inadequately dealt with in philosophy or in systematic philosophy. And what you really need at that point is not, and what really helped you as well in your own personal experiences and what you found helpful was not just reading the works of philosophers, but looking at what is required of you. I mean, looking at your own personal subjectivity in that moment and in that scenario, which was, I mean, it was much more about embodiment and about practice rather than about any theory. And finally, I just also want to know from you, this seems a very bit like the Taoist way of looking at ethics, for example, where ethics is seen more as a skill rather than as a theory. There's something you get better at practice and embodiment.
I think that's true. The Taoist way, or maybe it really is the same as ethics in Hindu practices like yoga, etc., where it's the practice that matters. Yes, I'm with you on that. William James was important to me because he was a physician philosopher who insisted that all knowledge that really matters comes out of experience. It's not free-floating, it's not just theoretical abstraction or greatly coherent systems of ideas that we build. It's knowledge that comes from the way our lives are, what we've learned in our lives and what we haven't learned in our lives. It's focusing in the empirical, on the empirical aspects of experience. That's where knowledge lies. And I just took James a little further and said that, yeah, but what kind of knowledge is it? Most of that knowledge, in my view, is wisdom about the art of living. And if we look closely at problems we have in our lives, like bereavement, when my late wife died, who I was married to for 46 years, we look at bereavement, we look at terrible, stressful situations, we look at failure, we look at injury, and we recognize that the question is, how do you live your life in the context of those things? How do you keep going? What is an adequate or a good life lived in those circumstances? It all turns on the question of the art of living. And I think the art of living is informed by this wisdom out of lived experience. And that's what I have been writing about most recently.
We are joined today by Dr. Arthur Kleinman, who is a physician and anthropologist. He's a leading figure in several fields, including medical anthropology, cultural psychiatry, global health, social medicine, and medical humanities. And he's also a China scholar. Dr. Kleinman, thank you for joining me again.
Thank you.
So, as an introduction about yourself, can you speak a little bit about, I mean, of course, you talk about this in your book, which is something I really appreciate, the Soul of Care. You talk about it in a very autobiographical form, about your own intellectual inspirations and your inclinations and why you chose the path that you chose. Could you maybe speak a little bit about that?
Well, I think in medicine, there's a long tradition of physicians who have thought about deeper questions within the doctor-patient relationship and within the setting of epidemics or pandemics or particular disease processes and other things like differential access to services and social and health discrepancies. You can't not think those things when you're in medicine. You're always brought up against existential matters that make you think deeply, I think. And there's a long tradition of this in medicine. And that's why so many doctors have become essayists or writers or gone off to do different fields. And in my case, what had struck me the most at the onset of my career was when, during the Vietnam War, I was sent by the American government from the National Institutes of Health, where I was a clinical fellow, to Taiwan. And in Taiwan, I originally went to do research on leprosy and tuberculosis and the way that stigma affected those conditions, and therefore contributed to people dropping out of healthcare or not accessing it on time, or doctor shopping and forgetting about the medicines that were important, or simply getting lost in the plethora of health services. And I was very intrigued by a particular observation that when I walked around the city of Taipei, you came to an area that was quite famous, which had a temple in it called the Dragon Mountain Temple, Longshan Miao. And around this temple were an incredible number of health-related facilities. You had small hospitals, doctors' offices, pharmacies, but you also had all kinds of traditional medicine, from traditional Chinese medicine to spirit mediums and interpreters of fortune. And so I was very impressed by this density of care. And I realized that the blueprint put out by the Ministry of Health, the Public Health Ministry, didn't capture this at all. And in fact, with the exception of noting some of the biomedical facilities, or what you would call in India allopathy, it didn't pay attention to any of the other facilities as part of the healthcare system. But you had to, because, for example, in a pharmacy in Taiwan at that time, you could go in as a patient and you didn't need a doctor. You could get access to virtually any kind of medicine, prescribed either by the pharmacist or just asking for yourself. So that the pharmacy was in some ways more important than the primary care doctor at that time in accessing the healthcare system, or at least its products. And there was traditional medicine and there was religious healing. And I realized, my God, this all comes together. And this is the bigger, the greater healthcare system, of which allopathy, biomedicine, is only a fraction. And that led me to do a study. I did a study in which I had people keep health journals, listing on a day-to-day basis there whether they had any symptoms, and if they had symptoms, what they did about it. And I discovered, and that was in my first book, Patients and Healers in the Context of Culture, that over 75% of the time, illness episodes, so described by people in their diaries, were only treated in the family and never went to the biomedicine system. They were in the family. They may have made use of a pharmacy or a traditional medicine pharmacy, but they never went to biomedicine. And even when they went to biomedicine, in terms of going to the hospital, going to a clinic, etc., the family was still involved. So the families were involved in something like, I forget the figure, but it was over 95% of all the illness episodes. And they were important. So for example, you went with complaints of arthritis to see a doctor, you came out, and then you made a decision in your family whether you were going to go back to that doctor or try someone else, whether you're going to use traditional medicine, whether the medicine you were given you're going to take. The decision-making of this was very much in the family, or maybe the broader social network. And that was, it wasn't like people were unaware of that, but when I presented it, it counted. It was a direct contradiction to what the public health and health services researchers of that time thought of as the formal healthcare system. And this system that I was describing was much bigger than the formal. And it led to a kind of Copernican change in our vision. So it was like the understanding that the Earth didn't move around, I mean, the sun didn't move around the Earth moved around the sun. What's the right word? It reduced the significance of the centrality of biomedicine and made it clear that if you were interested in healthcare and what people did when they were sick, then the central figure was the sick person and their family or social network and what they did. And that was economically most central, that was practically in terms of things being done, and it was symbolically most central because it was in that context that things got put together that biomedicine separated. So at that time, biomedicine was very anti-religion, very anti any kind of spirituality. It was very much humdrum, mechanistic understanding of the body. And what was astonishing to me was the recognition that in families, things that biomedical physicians thought were totally contradictory actually weren't a problem at all. Families had no difficulty in deciding whether to go to a traditional Chinese medicine physician or a biomedicine physician, to see both, to take both kinds of medicine, etc. We know that today, we take that for granted. But I can tell you in 1969, when I started my work, that was not taken for granted, okay? So that's where I began with that insight. And it just deepened over time. I became more and more interested in caregiving in families. And in my book, The Soul of Care, that's what I emphasize. Caregiving, not just as a phenomenon in medicine, but in families, and the threats to caregiving in families as there are threats to caregiving in medicine. And clinical phenomenology of illness experiences. How did people actually experience a disorder? How were their symptoms and their lifestyle shaped by their cultural context? And how did this interfere with the way that medicine viewed illness? So for example, if you picked up at that time a textbook of pathology, the pathology was simply about the list of symptoms and the changes in tissues and in organs. It didn't take into account at all what patients thought about the illness, what they did, how they experienced it, how were symptoms experienced. And so that intrigued me. And I recognized that much of the classical description of a whole bunch of disorders were based on Western populations that made up less than 20% of the world's population, yet they were the classical descriptions of the disorder. And so when you went to a place like China or the Philippines or Indonesia or India, and you saw other kinds of presentations of illness, it was always regarded as quote unquote atypical. And that astounded me. And I because in fact, these were the classical cases and the West were the atypical ones. And so my career grew out of that. In the first phase of my career, I'd say the first 15 years or so, that was my focus, those set of concerns. And then over time, the trajectory of my career took off in different ways. I had my own training was that I went to medical school at Stanford. I did my internship in internal medicine at Yale. I went to the NIH to be a clinical fellow. And I came back and did my psychiatry at Massachusetts General Hospital at Harvard. And I was trained in consultation liaison psychiatry, that is, psychiatry applied to medicine and surgery, internal medicine and surgery. And I had my first tenure job at the University of Washington in Seattle on the west coast of the US. And then went from there, and up through that period of time, my central focus was sort of bringing together medicine with local knowledge or local practice. And that required me to learn anthropology. So while I was at Harvard, I took a master's degree in anthropology, put them together. And then over time, my trajectory took a different tack, as when I came back to Harvard as a full professor in 1982, I was split between the anthropology department teaching medical anthropology and the medical school doing all the other kinds of things that I did. And increasingly, my interest became an anthropological one about different questions of a broader significance. So, for example, how did the sensibility of the doctor, his sensitivity, his feeling for others' experiences and his own, how did that come to influence the practice that he did? And I use the word he because at that stage, most doctors were men in the United States. Laterally, most have become women. And then I asked questions about what were the thought processes by which doctors and patients examined the same kind of problem a patient was having. So a patient with congestive heart failure and shortness of breath, seen by both an ordinary primary care physician, a cardiologist, and by the patient's family, what were the difference in the understandings that they had, and how did that affect their lives? And I came to two understandings from that. One of them, that there was a clash of ideas. There was a controversy, as it were, but it was a hidden one because of the power differential of doctors to patients at that time. Patients didn't usually share the disagreement with physicians. Now they do. Then they didn't. And I described those kinds of things. And increasingly, I became concerned with another aspect of patients' understanding, which was trying to make meaning of the experience of illness, trying to understand why me, why at this time, why am I having so much difficulty, or why am I having this particular difficulty? What do I do in the future? What will my life be like? All those questions I examined in a book called The Illness Narratives, about patient stories. And I showed why it makes sense for doctors to understand patient stories. And then from that, not surprisingly, I think, my interest floated out away from just being centered on the doctor-patient relationship, or even for that matter, on the hospital and the family home, to broader questions about the values embedded in the experiences of suffering of patients and of physicians. The larger issues about why was it that patients who were poor were so vulnerable to disorder? What was it about poverty that produced this? And, became interested in structural violence and how some people are, their very place in the social order produces a kind of violence toward them that leads to health and social disparities. We take this for granted now, but when I was doing it, there were really no markers. And so the great the exciting thing about my career is I always was a front runner. I was breaking new ground. And I think that's what kept me active and alive and excited. Others came along, did very, very good work, maybe the better work than I did on any of these topics. But it gave me sort of a sense of moving ahead. It's like when you're I don't know whether you're a hiker or you like to go walking somewhere. So you go walking somewhere, and all of a sudden the trail divides, and you get a chance to go off in your own direction, and you get excited because you feel, oh, isn't this so interesting? I'm seeing something new now, opening up a new way. Yeah.
Yes, there's so much to pick up from there. But if we could hone in on psychiatry, for example, I mean the importance of anthropology in psychiatry, and of course you mentioned in your book Rethinking Psychiatry that psychiatry suffers from this cultural myopia.
Yeah.
And, which is
sure. I'm happy to respond to that.
And just one more aspect, if you could address this as well. I mean, do you think there has been an increasing ascendancy of the neuroscientific and the biological or the biomedical approach in psychiatry? And
yeah.
And I mean, what do you think is the scope for the kind of things? I mean, what is the present state of psychiatry for these?
Yes, I'm happy to move in that way.
Because I mean, my own personal interest is to become a psychiatrist, but I have certain hesitations for that as well because of the increasing dominance of the biomedical model.
Yeah, I can understand that for certain today. Well, around 1972, I had just come back to Harvard from Taiwan. I came back in 1970. I came back initially as a postdoctoral fellow in a program on comparative health systems. And I was writing my first articles, which would all be published in 1974. And there were 4 or 5 of them. And they pretty much defined my career. The interests I already have explained to you. But I had to figure out, well, what's the next step for me now? And really, it was a choice of what kind of postgraduate training was I going to go into. And at that time, it struck me that psychiatry had the greatest interest in anthropology. And this had been going on for some time. In the late 1930s, through the Second World War, through the 1950s, there was a coming together of some anthropologists, psychiatrists, and psychoanalysts in a school called the Culture and Personality School, which tried to understand how society and the individual shaped each other. And we know many of the people who wrote in that time today as sort of classical figures in anthropology or psychiatry. In anthropology, it was Margaret Mead, Ruth Benedict. In psychiatry, it was people like Harry Stack Sullivan, the great social psychiatrist. It was a group of psychoanalysts. And then by the time I came on the scene, that influence was still there, but was dwindling. And I realized that psychiatry was the field in which anthropologists would be most comfortable, but still it seemed to be changing. Yet the alternative to it for me would have been infectious diseases, because I was very interested in infections. diseases. And at that stage, it didn't look like infectious disease or any aspect of internal medicine would have been as welcoming to an anthropologist as psychiatry. So I went into psychiatry. I trained in psychiatry. And there was another factor, important one, which is I had two very significant mentors, both of whom were senior psychiatrists, one of whom, Leon Eisenberg, was the head of psychiatry at the Massachusetts General Hospital, probably the most academic psychiatry program in the world at that time. And the other was a psychiatrist who was moving in the direction of what we now call health policy. And that was the great David Hamburg, who later became head of the Institute of Medicine, and then later the president of the Carnegie Corporation. And they both suggested to me that psychiatry was the field for me. So I went into psychiatry. But the kind of psychiatry I was interested in was really not so much chronic mental disorder as it was bread and butter anxiety and depression and their relationship to medical conditions, largely chronic medical conditions like diabetes, heart disease, hypertension, cancer, asthma. I was very interested in that interconnection, in what at that time was called psychosomatic medicine, or today we would refer to this this area of concern as sort of stress-related disorders, or the psychological consequences of medical conditions. And that was my interest. And that was what the Mass General was strongest in, consultation, liaison psychiatry. And that's when I got trained that way. And then when I went to my first tenure job, as I mentioned, my responsibilities in the psychiatry department interest was sort of bringing that together. So to understand how culture and social factors like class, poverty, have their work through the shaping of the body and of the mind of the individual. Now, increasingly over time, as I was moving in that direction, psychiatry itself as a field began moving in the opposite direction, increasingly toward its biological bases, toward neuroscience, etc. And intriguingly enough, and paradoxically, infectious diseases, which is the field that was my second choice, infectious diseases moved much more toward the social sciences, okay? So if you look at them today, in infectious diseases, you've got all kinds of people with an anthropological interest or orientation, and in psychiatry, fewer and fewer of those, okay? And so, and that's surprising. If you look at my students, for example, I've had more than 100 PhD students, of whom 25 have been MD PhD students. Most of them have gone away from psychiatry into internal medicine, infectious diseases, other related fields.
Such as Paul Farmer, for example.
Yeah, Paul Farmer, Jim Young Kim,
Yes.
who was head of the World Bank, Ann Becker, who's a professor of psychiatry at Harvard, was a little different, but she's now the dean for clinical and academic affairs at Harvard Medical School. Many people. So where is psychiatry today? How does that? So I wrote a piece with a young psychiatrist who's a good friend of mine, Caleb Gardner in the New England Journal of Medicine about a year ago or so, called Medicine and the Mind. And in that piece, we charted what's happened to psychiatry. And we drew on some very important recent reviews, of which one of the most important is by a colleague of mine at Harvard, who's in the history of science, whose name is Anne Harrington. And her book is called Mind Fixers, Mind Fixers. And Harrington shows that if you look over the last 40 years in psychiatry, you see that the great promise of biology has failed to materialize. And right now in psychiatry, although psychiatry is so biologically oriented, we don't have a single understanding theoretically that's been proved by empirical data of how our medications work. We know we have effective drugs for depression and anxiety, but we have no understanding of how they actually work. We use them more or less like empiric physicians at the end of the 19th century used medicines like aspirin or the few available compounds they had to empirically, without understanding how it worked. The same thing with same situation with regard to the major theories we've had in psychiatry. The serotonin-based theories all been shown to be incomplete, inadequate, and no longer useful. If we extend psychiatry to include not just mental disorders, but the nearby neurodegenerative diseases, and I believe that Alzheimer's is as much a psychiatric disorder, dementia of all kinds, not just a neurological problem. We look at Alzheimer's. We don't have the slightest idea now what the cause of Alzheimer's is. We recognize that the big focus for 30 years, or maybe 25 years, on a deposited amyloid in the brain has nothing to do with the cause and doesn't seem to have an impact vis-a-vis the treatment, and is a kind of a red herring because it's probably a marker, a scar, a marker of injury rather than causal. So in a disorder as basic as Alzheimer's, we simply don't know the cause. But what is the problem in Alzheimer's? It's the care of people. What is the problem in depression? It's the care of the person in the family. What is the problem in schizophrenia? It's care. And so my focus has been on caregiving as the central question. Neurologists in the neurodegenerative disorders have dropped the ball entirely on that. Psychiatrists, not quite so bad. If you look at the difference between neurologists and geriatric psychiatrists dealing with dementia, you'll see that geriatric psychiatrists have done many important things having to do with caregiving, okay? And are very useful to families. Neurologists, after the original diagnosis, are useless, in my view. And that's sad. It's a sad comment on their refusal to take the aftercare and the caregiving in the family seriously. So I see psychiatry as broken today, if you will. I think that the important issues we recognize are in global mental health. They're the evidence we now have that you can treat depression, anxiety, and even more serious chronic mental illness, that is bipolar disease and schizophrenia, using community health workers. It's a very, very important development. And that will come back to be the case in the United States. We've started it by the great progress made in Africa and India. In India, you have my colleague Vikram Patel, who's made tremendous progress in this area of community health workers. Then we have the in addition to community health workers, we have the recognition that the stigma associated with depression and anxiety world is changing, and it's part of a global cultural change, so that it's reducing amongst younger generations. And that's a very big deal, because it means that people are more to talk about depression and anxiety and to explore various ways of treating it. So in China, where I do my work, there's been an explosion of psychotherapy. If you had asked me 40 years ago, 50 years ago, would China develop psychotherapy? I would have said, no, no, no. It's very somatically focused. But in point of fact, for the young generation in China, there's a tremendous interest in psychotherapy, even in psychoanalysis. Okay? As people try to understand a purposeful life and come to terms with those things that we know but are unable to say, or that we say but we recognize we don't fully know. That's the unconscious. That's the social world around us. So I'd say psychiatry is in the following situation. Certain aspects of psychiatry are enormously important. Adolescent psychiatry and the substance abuse epidemic and suicide. Perinatal psychiatry for mothers because of depression, perinatal depression, and suicide, young women, maternal mortality, the elderly and dementia, and also depression, bipolar disease, and clinical care for that problem. Chronic mental illness, which in my country, we don't even have a mental health care system. The chronically mentally ill are on the streets, living homeless, or in the prisons. I think that attention to all these sorts of issues makes us realize that biology, even if we learn more about it, and I very much hope we do, is not going to be the solution. It's going to be a biosocial solution, as it is with infectious diseases. The more we learn biologically, the more important the social will be. And we have to come to terms with the way they come together. So, for example, one of the things that's so surprising to me is if you look at the kinds of questions that psychiatrists are asking and the kinds of questions that neuroscientists are asking much more interesting questions and getting much better knowledge, better supported knowledge than our psychiatrists. And they're asking very basic questions about emotion and the social world and the biological basis of it, et cetera. I think these are very exciting. But I find psychiatry somehow defensive because it has been, I think, so poorly served by biological research. Yet the commitment to biological research has overwhelmed the field and meant that psychosocial researchers, public health researchers, just about every cultural set of researchers have been underfunded, discouraged, and are not as developed as they should be. So in theory, I think psychiatry is a great field. But in practice, I think it has all kinds of problems today. I'm not sure myself, if I were starting off in your position, if I would go into psychiatry today. As I said, I might be much more tempted to go into yeah. Any other questions?
Yes. Sorry, I got disconnected back there. I mean, actually, I was just about to ask you the same thing. I was about to ask you, I mean, what you would have done had you been starting at this point? Because I think, I mean, as the situation has progressed, I mean, and as you said yourself, that perhaps you wouldn't have taken that route of psychiatry, might have gone towards infectious diseases
Yeah,
or something else.
I should be careful in what I say. Sometimes I say things a little too quickly. If I went into psychiatry today, my interest would be geriatric psychiatry. I'd work with dementia, because I think that that's all about family care, the relationship of care in the hospital, care in the nursing home, care with the family. I think that so much can be done on the caregiving side of that. I'd be very tempted. I think geriatric psychiatry is a great field. I think if I was going in today into psychiatry, I would think about adolescent psychiatry, another great field, and concerned with the substance abuse epidemic and the like. But I think the equally attractive to me would be to go into infectious diseases and work on global health problems like tuberculosis, HIV/AIDS, and epidemics like Ebola, or pandemics like COVID, where I think only in 1972 when I made my decision to go into psychiatry. Having said that, let me just say, I don't think that I've wasted my time or made a mistake going into psychiatry. Eventually, come to the point of view, side with its biological base, it has to develop the social science base and bring them together. I think that the connection of anthropology and psychiatry is a very important one, very, very important for both fields. For anthropology and the other social sciences, psychiatry insists we take the individual seriously.
I think the connection seems to be a bit shaky. Do you feel that as well?
I hear you fine. But I think we may be running out of time.
Yeah,
I've got to finish up here.
Yes, of course. Yeah, definitely. I'd like to touch upon a few other questions which have to do with more general or broader concerns in your work. For example, what really matters is one of your books where you look at the what you term the local moral, the importance of that.
Yeah. Yes. So let me take these through. Yeah. So in 1998, I had the good fortune of being asked by my alma mater, Stanford University, to deliver a famous set of lectures called the Tanner Lectures. And in those lectures, I was supposed to address some aspect of the issue of values in society. And I chose to look at an anthropological approach to ethics, including medical ethics. And I suggested that the way we do medical ethics is distorted. Much as I had seen earlier, that a vision of healthcare that was centered in how people lived was more adequate than seeing it from the perspective of the medical system. I came to the recognition laterally that a more adequate understanding of values, of ethics, was beginning with the way people actually committed themselves in their lives to certain values. And I call that what is at stake, and saw people as stakeholders who were committed to certain kinds of things through their actions. As an anthropologist, we tend to be very suspicious of what people say they believe in, and much more willing to accept their actions as a demonstration of what they really are committed to. And so what I described was that all of us live in local worlds. And these local worlds are moral in the sense that our families, our networks, our works settings are all about certain kinds of commitments. So for example, you might walk into a clinic and the sign may say, serve the people. But in fact, after watching what people do and working there, you realize the real commitment is to generating income and making money, okay? There's a discrepancy there between what's said and what's actually practiced. And what's actually practiced is what I regard as moral experience. And in what really matters, I looked at the way that people in their lives are affected by discrepancies between the moral experiences of the groups that they're in and their own moral values, which may be in accord with the local world, but might be different. And so I use cases from research, from clinical practice, et cetera, that raise this division, this conflict between the moral experience of the group in the local world and the moral experience of the individual. And I show, for example, in one instance, a story of a soldier, a decorated soldier who goes on to a brilliant career later in life as a lawyer, but who committed an atrocity as a soldier, who never forgot it. And it comes back to haunt him both in the body and in the mind when he becomes depressed, seriously depressed later in life. And I get a chance to treat him, and his depression leaves, but he's unsatisfied with simply feeling better because he knows he hasn't come to terms with this central issue of guilt, of the need for redemption. Okay. And that goes way beyond the psychiatric problem. It is the moral problem. And I give other examples, a number of other examples of that. And look at the way
we can perhaps end with one more question, which I wanted to really get from you. You have an essay on the importance of William James called The Search for Wisdom.
yes.
And it is this philosophical side which I also want to hear from you about. For example, you mentioned in the essay that the questions of uncertainty and danger in the world are inadequately dealt with in philosophy or in systematic philosophy. And what you really need at that point is not, and what really helped you as well in your own personal experiences and what you found helpful was not just reading the works of philosophers, but looking at what is required of you. I mean, looking at your own personal subjectivity in that moment and in that scenario, which was, I mean, it was much more about embodiment and about practice rather than about any theory. And finally, I just also want to know from you, this seems a very bit like the Taoist way of looking at ethics, for example, where ethics is seen more as a skill rather than as a theory. It is something you get better at practice and embodiment.
I think that's true. The Taoist way, or maybe it really is the same as ethics in Hindu practices like yoga, etc., where it's the practice that matters. I'm with you on that. William James was important to me because he was a physician philosopher who insisted that all knowledge that really matters comes out of experience. It's not free-floating, it's not just theoretical abstraction or greatly coherent systems of ideas that we build. It's knowledge that comes from the way our lives are, what we've learned in our lives and what we haven't learned in our lives. It's focusing on the empirical aspects of experience. That's where knowledge lies. And I just took James a little further and said that, yeah, but what kind of knowledge is it? Most of that knowledge, in my view, is wisdom about the art of living. And if we look closely at problems we have in our lives, like bereavement. When my late wife died, who I was married to for 46 years, we look at bereavement, we look at terrible, stressful situations, we look at failure, we look at injury, and we recognize that the question is, how do you live your life in the context of those things? How do you keep going? What is an adequate or a good life lived in those circumstances? It all turns on the question of the art of living. And I think the art of living is informed by this wisdom out of lived experience. And that's what I have been writing about most recently. And I'm literally writing about it right now. So that's a good place to end. It's really been a pleasure talking to you. I'm so delighted that you are a student of my work. I wish you the very best in your career.
Thank you.
And don't take too seriously what I said about psychiatry.
Of course.
Psychiatry can be a great field. It's like an arranged marriage in India. You might not know the other person very well, but over time you come to love them, okay? You learn to love them.
Yeah.
So I've learned to love psychiatry over the course of time.
Yeah. Thank you.
Good luck. Take care.
Thank you.